right, good afternoon. Welcome everyone. Hopefully you guys can stay awake for this presentation because it's going to be a good one. My name is Karen Gauthier and I'm with LK. We like to call ourselves the healthcare data plumbers, and we are leaders in the industry for interoperability, data conversion, data archiving, and lab connectivity. So welcome to our next session titled Digital Health Lessons Learned and Stories to Share, presented by Joe Diver. So he is the Chief Information Officer at Holyoke Medical Center. So Joe's experience includes over 25 years in the health tech leadership, including CIO, digital innovation strategist, and project leadership for health systems ranging from 500 million to 4 billion in revenue. His experience also includes vendor leadership, including EVP for a leading health science company focused on improving care for patients with diabetes. Currently, Joe is the Chief Information Officer at Holyoke Medical Center, leading digital strategy to improve patient engagement and outcomes for a very diverse population. Please join me in welcoming Joe.
Awesome, thank you for that great introduction, appreciate it. I was honored to receive the request to present to you today, and I structured this in such a way that it's very collaborative and open conversation, and there are going to be some great stories to share and the kind of like the steps that have been taken to through this process. But my primary objective is this, okay? So pretty good, don't fall asleep, and we'll be great. So starting off with the definition of what is digital health. And this is from Himss back in, as you can see, March 2020. Connecting and empowering people to transform that care delivery. So a little bit about Valley Health is the parent company where the management team sits. Holyoke Medical Center, Holyoke Medical Group, the physician group, VNA, River Valley Counseling, over 330 physicians and advanced practitioners. It's been open for quite a while, 1893. We serve 60% of Holyoke, 18% of Chicopee, 6% of South Hadley, Springfield, but the bottom line is the biggest, plus 75% government pay. So how do we stay ahead of the curve to survive and thrive in the shadows of a $4 billion health system 20 minutes up the road, and another one a little bit further to the east? When I decided to join the organization 105 days ago, that was my big question: are you going to stay independent? And the answer from the leadership and the board was absolutely, because we have a community to serve. So that was inspiring, and I could see the passion from that leadership. So the lessons I'm going to share with you today is really along my own personal journey and the experiences I had with some great colleagues through the years. I'm a husband, father, and as we all are, patients at some point through our own journeys. Baby girl, 17-year-old today, but when she was born, 92 days in the NICU, 4 transfers between South Shore Hospital and Children's Hospital in Boston. I had no idea what the hell was going on with her clinical data. Thank goodness she received great care, and everything turned out fantastic. And my career took off to become the CIO of Berkshire Health, VP for Physician Mobile Solution Product, EVP Life Science Solution for Diabetes. Remember that one, because I'm going to share something about my own personal health journey, which made me passionate about digital health. Innovation Strategist at Bay State Health, and now CIO of Valley. Asking these questions about what makes you tick, what drives your innovation spirit to leverage different programs, some a niche, around the edges of the EMR that you just invested 140, 200 million, 50 million, whatever the number is, to add technology around that from a digital health perspective. How do you continue to drive value? That's been one of the barriers through the years, is Why can't our vendor do this, or why can't this be done? And just keep that in the back of your mind as we have this discussion. So my passion is to improve care delivery. Very curious. I'm not the expert, but I am a patient. So again, how do I want to have my own journey through healthcare? Very empathetic, walk in the shoes of your nurses, your doctors, your patients, everyone. When you look at your Community Needs Health Assessment Report, everybody does one, what is that number that causes the cost of care to go up related to social determinants of health? The average I've seen is plus 40%. Keeping that in mind as we look at digital health. My belief, and I think we all share this, things can be better. Things can improve. And then what is your own life and health journey? So by the numbers, here's a patient story. Between 2014, 2017, 3 years of business travel, 100,000 air miles, 35 pounds of weight gained. A1C is 11. Blood pressure, 145/90. This patient was feeling horrible, no energy, stress was up. That's me. So when you go to your doctor says you're off the rails, you need to improve your health, where do you start? I was working for a company focused on diabetes with virtual health coaches, engaging with direct primary care doctors. So what does that digital health cause and affect? I got engaged because I shared the story with a colleague who was a health coach, and she said, you need to do this. And over time, 40 pounds came off, A1C's an 11, blood pressure around the 112/75, back on solid ground. That's why I'm a believer. Okay? So digital is changing how services are delivered and how organizations define value. From a fragmented system to a connected, from episodic to continuous, from reactive to proactive, from access constrained to access enabling, fee for service to value-based care. That's the conundrum. How do you leverage digital health where you're going to reduce visits and impact your fee for service model, but how do you align it with the value-based care model? What is the economic alignment for digital health strategies, solutions, et cetera? So this is audience participation now. If you're a large health system, and I'll just use a number of plus 5 billion. Anyone? Okay, seeing none. Okay. Mid-size, 1 billion to 4 billion. Seeing none. Small health systems. There's one over there. Payers. Vendor community. Aha. There we go. Oh, ACOs, thank you. Yes, ACOs. So that is great because these stories will be very applicable for what you're trying to achieve for the companies you work with. So lesson one, and this is really more for the operational side of the health system, is where to begin. It's your team culture and providing time for that innovation. If you don't have an innovation center in your health system, so if you're a vendor, that might be one of your qualifiers. Is, if you're trying to do something new from a digital health perspective, who is your innovator? Who is your team at that client or that prospect to be able to, again, on the edges of your EMR, deliver something that's high value and will make an impact? So when I was going through my interview process at Holyoke Medical Center and Valley Health System, I had a panel discussion with 12 people from IT, my future team. And I asked them the question, what percentage of time do you spend on keep the lights on, growing the organization, and innovation? After they stopped laughing about time for innovation, these were the numbers. It's like 85% keep the lights on, 15% grow the organization. That really wasn't growth. It was just new technology kind of coming at us, upgrades and things of that nature. I said, what if we begin the shift? What if we begin a shift of 75, 20, and 5, just to start? And they said, not doable. Why not? Well, we don't have the time, we don't have this, we don't have that. Well, let's look at the efficiencies within how we're making decisions on projects, and let's look at our high-value projects versus those that can be deferred, just to create a little wiggle room. 5% of time over a year is not a lot of hours. And within 60 days, we had our first innovation project movement. We just went live this week. And the team is going, you gotta be kidding me. 400 text messages go out to patients. How many opted out of those text messages? 0. How many opted out of the emails that were coming at them? 10, because they prefer text messages. We just learned something about 400 patients or consumers in a very short period of time. Now what can we do to then grow and scale that type of program? And with that, we're capturing patient-reportable social determinants of health, SOGI, REL data, all the stuff that we're trying to get at. So then how do we then bring that back into our EMR? And then that's Horizon 1. Horizon 2 is what do we do with that? What do we do with that data that we capture, and how do we continue to move that program forward? So the other lesson, again, I saw a lot of vendor hands, not many health system hands, but thinking about the health system side, FTE constraints are real. To get new FTEs to do something new, impossible. That's why I try and get that 5%, because I know I'm not going to get new FTEs to do digital health experiments or innovation. Again, open that time to engage the team members, and that open time for team members to be able to participate, their satisfaction, their engagement goes quite up. I had one staff member come to me and said, I've never been so happy to get in my car and go to work. That's huge. And the last, that opening that time is very hard, but very rewarding. Lesson 2 is aligned with a strategy or a passionate problem. And there's many more bubbles you can put around the hospital, the health system, the issues we're all dealing with, whether it be an ACO. So we all are trying to improve quality. We have competition, improving patient experiences, service line growth, and improve quality again. Because it's all about quality. And for me, why is it about quality? It goes back to the previous slide where I highlighted 75% Medicare, Medicaid, government pay. I have to improve quality, reduce readmissions. I need to stay ahead of the curve with those incentive programs. But once you have that alignment, start with the experimentation. Don't have to solve the whole problem at the one time. So I think it was like 90% vendors raised their hand here. Very, very important to figure out what is the problem, what is the passionate problem that your client is trying to solve, either on a grand scale or a small scale. Who hates the word pilot? Raise your hands if you hate the word pilot. Come on, you're all vendors. There's one. I don't use the word pilot. I use the word experimentation. Because if you tell me it's going to solve a particular problem and change some needles for me, I want to see those needles change, but I have the reverse commitment to say, if we change those needles, we're going to scale. And we're going to go bigger and broader, et cetera. So will patients adopt the digital health tool? How many people have heard about human-centered design? Okay. Extremely important to engage patients, consumers, community members, and of course your clinical team when you're looking at digital health. Will they adopt the technology? Will they do their part as a patient in their continuous care journey? And then, is the expected impact showing those early results? So my whole colleague from Bay State over there, Patrick, is there. Katie Barker is one of the best physicians I've ever had the privilege to work with. So this story, and you can see her quote, she'd have a bake sale for this particular technology. And when she expressed her passion, the issue that she was trying to address was moms at high risk for preeclampsia. Of course, COVID kind of brought the discussion to the table, but she was thinking about that 18 months before COVID even hit. So when I saw the passion in her eyes, and I was collaborating with others around an FCC grant, I snuck it in to see what we could do. The vendor partner we were working with, I said, I can't give you a big contract. We might start with 50 patients. Are you willing to innovate with us and see the results? And they said yes. That's where we started. Those 50 patients, we had great results, great engagement, physicians loved it. Then we snuck in another grant and got another, X thousands of dollars and did that. Here's the great part. When you're looking at ROI, this story you cannot calculate ROI. 2 moms, pregnant, clinical plan, early delivery, NICU stays. The blood pressures were controlled much better because of the system. Moms and baby went full term and went home 2 days later. Amazing. So that story, and you'll see another lesson is about the internal marketing to the board, senior leadership. At Bay State, when I was, again, this is prior organization I was with, when the CEO of our payer system saw that, Health New England, he said, how can I get all of our members onto this program? Now is a joint deployment that Health New England covers this particular program for all their moms going through OB. And we started with 50 patients, a vendor partner willing to work with us, innovate, and grow. Last count I heard is over 2,200 moms have been impacted by that program. So again, that lesson 2, that OB RPM, is experiment, grow, and then scale. You don't have to get to that scale point right away, but with the right clinical partner, an organization that provides that time to innovate, and a partner, vendor partner, willing to work with us, we achieved miracle results. Not so much for us, but for the patients. The other story is, I think everybody is aware that there's a high mortality rate for African American moms and children. We had a patient quoted in our post kind of survey process that she felt safer, more educated, and just had a better experience because of this program and that tight connection with their providers. Lesson 2, this should be probably, I don't know what lesson I'm on. This one is quite interesting. In Massachusetts, there's a group called MeHi, and they get government funds from the state to help innovate within the digital ecosystem of Massachusetts. They approached me and they said, we have a very unique asthma RPM program being developed in Massachusetts. Would you be willing to partner with us? Sure, that's what we do, right? I wonder if I have a pulmonologist that's willing to partner with me. I had no idea. So let me go do a gut check. I sat down with one pulmonologist and said, what do you think? Can we serve patients differently in this part of Western Massachusetts? He's like, what about rural patients? I said, what about them? Can we include them? Sure. What's the reimbursement? I don't know. We're getting some funding from the state. Can we start? Sure. That's how we started. We started with 20 patients, 50 patients, 100. And then we interviewed a patient who said, if I didn't have this, I think I would have died. I would have been in the ED, and I don't know what would have happened to me. In this program, we had multiple thousands of interactions from patients. 400 got escalated to the respiratory therapist that our vendor has on staff in a call center. 20 went to the clinician for action. So imagine if you have that volume of patients out there and that pulmonologist trying to manage his patient load, and he only has to respond to 20 alerts, he can now serve more patients. And now that program is also scaling. So I mentioned earlier about internally market the impact. So that's really just structuring it as those innovation stories, those digital health stories. What's happening internally? Are you in the middle of a major implementation? Are you trying to maximize and optimize your EMR? Where are all those other resources? What's going on? But if you take your organizational strategy, your community needs health assessment report, and point to, we have a problem with moms at high risk for preeclampsia. We have a population that's high risk of asthma. We have a population that's high risk of diabetes. We have no solution to really do the outreach within our EMR, so you start slow or start moving the ball forward at a very low cost. You get the attention of the board and the senior leadership to say, do more of this. Let's continue that ball moving forward. That's the H&E story for the OB. What's happening externally? Whew, boy, there's a lot. So when at Bay State, and now I do this at Holyoke, what's happening externally that could be a threat to the organization is one medical group moving in. What's Walmart doing? What CVS is doing? And if I look at what Hartford Health System is doing, they're not really a competitor, but I'm watching. You know, how are they engaging the Medicare Advantage patients? What's going on in that market? How is that going to impact our region? And how can we get ahead of that ball? So again, leveraging that kind of SWOT analysis in these stories and making a connection, you get the support you need to move the programs forward. Which I'll tie in real briefly is that when I interviewed for the CIO position at Holyoke Medical Center, I've known the COO, who's also the CIO there, for 20 some odd years, great guy. I called him, I said, what exactly are you looking for? It's all about digital transformation because we need to survive and thrive because we're going to remain independent. When I talked to the CEO, I said, what's the most interested to you? He said, I need a CIO who can transform our business. That's quite interesting. And you're going to make a bet in that. And it's going to be a lot of innovative digital outreach, digital health solutions. But in bringing these stories and bringing these opportunities to that senior leadership team and board, and we're moving forward on programs. So this is just a framework. You can create any framework you want. But the point being, what's that passionate problem narrative? That passionate problem, if it's not resolved, what are the consequences? Always have a clinical sponsor, executive sponsor. I think you guys know all this very well. If you don't have that connection, again, about 90% of vendors here, your project won't have success. And that is core alignment, because if you make a bet as a vendor and say, we're going to not go for the big price tag, we're going to help you scale. If your partner on the health system side isn't scaling with you or isn't doing their job, that's a conversation you automatically go up to the clinical or the executive sponsor and say, we need to shift or do something different. The narrative results and the measurable financial impact. They go to number 4. Don't underestimate that human-centered design and the patient experience. It's critical to get your adoption. It's critical to get the results. And we've tested this a bit over the years, when I was at Bay State and prior. If we just push a digital health technology to a patient, the adoption rate I saw was less than 20%. If I look at EMR portals, the average I've seen is anywhere from 12 to 20%. Imagine if you're a digital company and you can only engage 20% of your consumers digitally. When we said, well, let's experiment by having the provider introduce this digital health asset, this program, to the patient, adoption rates north of 85%. Continued utilization, 90%. So how do you engage the consumer? Again, we all are patients along our own journeys. Who do we trust introducing this particular technology? Me, the CIO? I hope not. Your physician? Certainly. Lesson 5 is that economic alignment. So again, vendors partner and align to the VBC. Everybody familiar with value-based care and the incentives? I won't say which organization it was, but I shared this story with a couple of the people earlier today. They missed an incentive payment from Blue Cross Blue Shield for A1C checks. HEDIS is 1 check a year. Blue Cross Blue Shield was asking for 2. They missed it by 45 patients. $200,000. Now, if you look at your PM alignment and your incentive programs, if I can take a small piece of that PM and put in digital health, we'll knock that out of the park. So how do we do that differently with that alignment to pop health? And I say initially because who knows what that model is going to be down the road. If I have 3 vendors coming at me and saying, we could do this, we can do this, just tie it to your incentive program. Well, I have a small little piece. How do I bring all of that together in one view? But establishing key deliverable metrics and putting value around that so I can look at the totality of it, then I can figure out what the economic alignment is. I can't do a $100,000 program here, a $100,000 program here, another $100,000 over here. I need to make sure that dollars are coming back. I need to make sure that that metric is hit out of the park all the time. That's the challenge. That's the partnership that's needed between digital health and health systems. Focus on the passion and problem. Don't just sell me a story. Understand us. If a vendor was to read my community needs health assessment report and understand the details in that and start the conversation there, you have my attention. Because my passion is my community. And if you become a partner, I want that same passion to help our community. So I think those are very important as you align that deal and both work to have that achieved impact. Again, don't pilot, but experiment. I had another vendor partner who said, I like your idea. I like aligning to the incentives. I haven't thought about that, but I need to grow and scale my own revenue stream. Can we put in some metrics that if we achieve those, that we go to a bigger contract? And the answer is yes. Because then those dollars are going to follow to be able to share that revenue and share that stream, if you will. So I'm going to stay on this slide for a little bit. But before I do, I'd like to just open up to the audience. Does anybody else have a digital health story to share? Personally, professionally, health system-wise? Anyone? How about a show of hands? Who's using the digital health app for your own? Raise them up higher. Oh, it'll be okay. A lot of folks. Are you seeing the value from those as yourself a patient? Now, how do we begin to give those same technologies to patients who are trying to put food on the table, get their kids to school, and figure it out? The cost has to be very low for the patient population, but the return has to be very high on the incentive side. I mentioned how Health New England leaned in for the OB program. I think the payers have a big responsibility in helping us fund these. I don't know if everybody's reading the latest of Massachusetts Health Economics, but if we make 1% margin, I think we have a pizza party at the end of the day. And everybody's hurting right now, so how do we make these bets and have those dollars come back into the organization to reinvest, et cetera, et cetera. This might be a little bit hard to see, maybe not, but there's a key line in here that caught my attention when I was being recruited. This is the first thing I looked at. If you read down, it says, I'll just read the whole thing. Our mission of Valley Health Systems is to improve the health of all people in our community. And I'm just skipping a sentence. We do that through expert and compassionate care, education and knowledge sharing, community partnerships, fostering innovation. You have my attention, Mr. CEO. You have my attention, board. Let's have a conversation. We had that conversation and went through the process. Interview round 1, interview round 2, interview round 3, hospital tour. Great. Where are we going? Well, we're just going to take you up to the 4th floor to show you something. Did I showed you? Mary, my colleague from Meditech, was there with me this day. They have virtual sitters. 6 sitters in a room. Each sitter is watching 8 to 10 patients on a monitor. Really? A small community hospital is doing this? Wow. What's the impact? Our fall reduction is this. We've saved this much money because of the fall reduction. Oh, and by the way, nurses on this floor receive an incentive payment if the falls are below X. Really? Fantastic. Learn more with the vendor that we're using. I said, what do you think about virtual nursing? Oh, we want to do that too. Will you experiment with me? Will you help me? I'm building out an innovation hub. I'll tell the stories if it's successful. Yes, we'll do that. Great, fantastic. Then I'm there week 3, I talk to my boss, I go, can I go to this conference called Vive? I've been there a couple of times, it's really cool, it's in Nashville, right? So it'll be a fun time. Sure, go ahead. I'm literally walking by the booth of that particular vendor for a virtual sitter program, and my text goes off. It's a group text from the CNO who was sharing a story about one of the sitters who noticed on his screen a patient that looked like they stopped breathing. Now, these virtual sitters are not clinical. You know, high school grads, you know, I don't think we have any college grads sitting there, but this particular person made an observation that patient was not breathing, alerted the nurse called the code, full CPR, code blue, yada, 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 patient survived. Put an ROI on that. You can't. So how do we do more of that kind of innovation in small community hospitals that can't, you know, otherwise afford that? So that's one story. Here's another story about innovation. I'm kind of getting out of the digital health a little bit, but just philosophically, organizationally, how many people have heard the stories about travelers and the expense of travelers in healthcare? What this place did, we're going to press down on that bubble by offering a $40,000 sign-on bonus to a nurse if she gives 4 years. So, wow, you're kidding me. How many nurses have you recruited? Oh, we're doing good. And now I'm there for like 2 months. We just looked at the numbers. The big boy up the road, we have 28 nurses that joined our organization, left our competitor. Huge, huge. So, you know, going back to digital health, you know, so first question, is this good? Did you achieve it? Okay. It's a true passion, but it's hard. It's hard to say, we're going to go do this particular program when we have this massive EMR system sitting there. It's challenging, but it all begins with that culture change. It all begins with the mind shift to that 5%. 5% grows to 10%. I was at a recent Chime focus group, and just sitting around the table, I don't know, 12 or 14 CIOs. And I said, who here is from a small community hospital that would want to partner with me on an innovation hub for community hospitals or critical access hospitals? As we work with partners and vendors and solve problems, how can we scale that across community hospitals and do the same thing in Washington, in California, in Iowa, Massachusetts, New Hampshire, Vermont? All the hands went up. How do we do it together? That's innovation. How do I learn from Intermountain in Cleveland and take these great things that they're doing and do it in a 210-bed community hospital that wants to stay independent? We'll see, right? But we have to start somewhere. Working with our partners, our EMR partner, looking at our population health strategies. How do we use those tools differently? And how do we then extend that? The other innovation that is being stood up at Holyoke, July 1st, is a metabolic clinic. The goal of that medical director of the metabolic clinic is to get patients with diabetes off their medications. Really? In Holyoke, Massachusetts? And we're going to start with 50 patients, but the population is over 8,000. Imagine that, right? So there's more digital health tools. We have 3 more RPM programs that can be deployed to support that metabolic clinic, and more importantly, support their patients on that journey of care. So with that, I welcome any questions. I don't even know how we're doing on time. I probably did like 10 minutes, I don't know.
Thanks for a great presentation. I was wondering if you could talk a little bit about when you're thinking about that innovation and starting with like a really small population and then you grow it and then eventually you're scaling it up to these really impactful programs. Can you talk a little bit about how the data collection and analysis challenges change throughout that and kind of how do you scale up the infrastructure at the same speed that you're scaling up the program?
Yeah,
what challenges do you face with that?
That's a great question, great question. On the beginning, in each of these programs, we did not, on purpose, did not interface data to our EMR. And the reason being is that we wanted to learn more about the clinical protocols, the clinical practice, what's more important for the providers in the clinical journey. As we scale and now start talking about interface into the EMR, because the value that we see has been achieved and the clinical need has been proven, the conversation to prioritize these projects into your integration plan becomes an easier conversation. So that's another part of the win. You're still kind of in line for that. But at Bay State, and we'll be doing something similar at Holyoke, we had a partner that's able to grab data from these RPM systems and the main EMR to bring it up into a different view. So you're getting creative around how do we bring that all into the clinical practice and clinical workflow. So I hope that helps you. Okay. Hello.
Hi, Joe. Great presentation.
Thank you.
I'm especially intrigued by what you were talking about at the end with the Innovation Hub with community hospitals and critical access hospitals. Can you say more about that? Like, is that, real early stages? Is it
very
evolving?
Yeah, very early stage. I actually have 3 innovator vendors that want to participate already, and but it's a very early stage development. And the idea is that for vendor partners, think of it as kind of tied to their R&D strategy of how do they develop product and then how do they get it out to market and be able to help community hospitals afford this and have the wins at the end of the day that line up to the economics, right? So it's very early stage, yeah. I'm actually, in complete disclosure, I'm actually stealing it from Joel Venko's TechSpring model a little bit. So I gave him a cocktail in Nashville, so he's fine. So.
Joe, so quick question with respect to, at the beginning you were talking about the 75% for ops, 25% for growth, nothing for innovation.
Yeah.
there's, in addition to the solutions themselves, you and I have had a conversation around the personnel.
Yeah.
How are you approaching that transformation of your teams that have been working in a very familiar, almost inertially driven mode?
Yeah.
And how are you helping them to understand what this transformation is going to mean?
Great question. I'm giving them room to fail. I'm giving them room to try something new. If they trip over their shoelaces, they learn. We all learn along that path. And give them that safe space to go try something new. Chris, I just wanted to do, she's just joining my team in September. And I was sharing a story about one of the team members who wants to professionally grow. And you know, one of the struggles for community hospitals is those merit kind of increases and things of that nature. So another innovative program is that at Holyoke Medical Center, if you have an idea to improve a process which reduces cost, you get 5% of that savings. So I showed that to her, and she's been through the organization for multiple years, and she goes, I had no idea. So she's flooding that channel with ideas, which is great. But you kind of creatively create those paths to be able to unlock it. But definitely give them room to grow and trip over their shoelaces, come up with ideas. Our philosophy when we get together as a team, I'm not the CIO, I'm a team member. Best idea on the table wins, right? And we figure it out together. So hope that it helps, Pat. Yes?
How do you know what's the best idea? I guess, like, how do you prioritize the innovations you want to tackle?
Great question. If I go back to the passionate problem and what the impact is, that kind of statement is the powerful tool that we look at and go, what if? You know, what is the opportunity? How does it line up to either our community's health assessment or our strategy? And one could argue most things will, right? What's the clinical sponsorship and their level of passion to solve the problem? If we get passion, we get a win-win-win, right? And sometimes you can't do everything, certainly. So then you just create your innovative roadmap, and actually then bring that back to the organization and go, okay, I started with this 5% growth in innovation. I did it with the current FTEs. Do we want to make a bigger bet? Do you want to add FTEs into this to keep this kind of thing, kind of feed and water it, if you will? But that's kind of the model that we're using. Yeah. So, and we never have like a no. It's a, you know, yes, and we're going to do it here. We're going to slot it for that time, kind of thing. Yes?
Within the context of your digital health strategy, how well are you fostering consumer patient engagement using the Meditech portal?
Great question. The Meditech portal utilization right now for us is less than 20%. Yeah, and we're trying to, we don't have a formal kind of digital front door yet. Okay.
Are you offering round-the-clock support for them if they have trouble using the portal?
Round the clock, not 24/7. No, yeah. Yeah, and in our organization, the portal is actually supported by medical records, or HIM, during normal business hours. It's a concern and an opportunity, because I think what you're hitting on is that even with the portal for looking at consumers, did some analysis about four weeks ago, we saw a huge number of people coming in after 7 p.m. to schedule an appointment or request an appointment, but now if they're active in that, how do you structure that? Exactly. Yeah. So how do we know what the consumers are leveraging our technology and build a structure around that? To that, I guess, taking your question just one step to the left, on our metabolic clinic, we're looking at standing up a white glove service from our help desk to support those patients who are using those digital health tools to make sure they have the support needed. Yeah. Oh. Hi.
So your metabolic clinic is interesting to me. I work for Tata Corporation, TCS, and I live in the future all the time. Digital twins.
Yeah.
We create amazing software that will nudge a person, will machine ML AI study all of their behavior and put the nudges in at the right place, the right time. Like
Yeah.
the sponsor of a program in London literally wants persons with dementia who are sad to have dinner with their grandchildren, and that's what sponsors us, is Pure Hearts.
Yep.
But my struggle is that I work as a nurse as well on weekends, and I feel like I'm back in a really scary place with my electronic health record. It terrifies me, quite frankly, many, many times. But how does we know that it's human touch, and any nurse knows, and any clinician knows, therapeutic touch creates miracles and breeds miracles. And with diabetics particularly, it's the human element of lifestyle behavior modification that takes years and years to stick. So how does one then develop the ecosystem where lifestyle medicine becomes the norm within our acute environments, where there's not funding for that right now, but therapeutic, touch, therapeutic relationships is all part of what we know as healthcare givers and nurses, and sometimes I see us forget that critical element, and we have to be willing to pay for it because it is the proven over and over. Diabetes educator studies of 2 years have shown that there's intervals at which a person has to see a clinician in order to stay on lifestyle task. So how are you with your clinicians addressing
That's a great question. I'm going to go back to probably 2017-18 on a lesson I learned back then to answer your question. When patients are entering the patient-reportable data, hypertension, diabetes, stress levels, whatever the case might be, when do they need to be seen by a physician, but also what is the relationship that they're seeking, right? So if we think of the consumer, I guess, preferences, my wife would want to be seen physically by her physician more often than I would. I would like to be engaged at a point where my sugar levels have risen, the variability of my sugar levels are all over the map, my weight might be increased and my stress level might be increased, and I might want just a virtual connection or a chat communication to say, hey, you doing okay? I noticed a different range, let's have a conversation, let's engage. And from that, if there's some clinical interpretation that I need to be seen, to then be escalated to be seen. Because if my coach tells me I should be seen by my doctor, I will go. Because I don't want, so how do you structure those? As part of the conversation, the planning. So for the metabolic clinic, for example, we're not going to do 100% virtual. There's going to be a clinical protocol and process where the patients do come in. But for those patients that have, again, social determinants of health issues, might have a transportation issue, we're going to arrange transportation. But if they prefer to be seen virtually, we'll give them that option. So it's kind of patient preference to close that loop a little bit. We don't know the right answer yet, but that's kind of where we're starting, because you can't, the therapeutic touch and that connection is important, especially for consumers of healthcare with loneliness. They don't have the companions, they don't have the people checking in on them. It becomes their avenue to address their clinical needs. Does that help? Okay.
Great presentation.
Thank you.
Trying kind of a little bit going off of that. I know you had mentioned better community and patient experience for both the patient and the caregiver. I saw Intermountain recently, so I know they have a very robust program of this. But what is your strategy, if any, on a hospital at home program right now?
Oh, great question. Great question. I just talked about this with the senior leadership team 2 weeks ago. And we're a very nimble organization, and we have 10 borders in the ED, right? We have this, we have that, we have the same challenges. How can we start using hospital at home? Oh, wait a minute, we have a VNA as well? How can we look at a whole ecosystem to build that out? So we're just starting the conversation now within the last couple of weeks. But it was about a year long of research and understanding when I was at Bay State to figure that out or collaborate with others. But interestingly enough, part of my other life is I'm on a select board, so I'm an elected politician in Dalton, right, which is out in the Berkshires. And the Berkshire VNA is going for a union contract with Berkshire Health Systems. And they had this public forum talking about the future of home care. I was excited. I got on that. I said, maybe they're talking about the future of home care. They were actually talking about their contract and the struggles they're having with the health system. I said, well, wait a minute here, right? So I asked the question, I said, what if Berkshire Health was to set up a hospital home program, leveraging the VNA ecosystem to drive lower costs and readmissions, higher outcomes and things of that nature, and the value of that is recognized, helps you with your union contract negotiation. Then, wow, what? Hospital home? So that's a direction we have to head.
I'd love to talk about it later.
Awesome. Yeah.
Just a quick question. You mentioned that a lot of these innovations or experiments that you guys are starting very small and then growing. Are you mostly depending on grant funding, or are you asking your hospital to find money to help pay for it as well?
Grant funding and or what I would call an approval economic alignment to a value-based care team. So if I look at anything on that list, I'm going to reduce, I'm going to go after those 44, 45 patients for A1Cs, or I'm going to go after more patients for hypertension. And we can watch that alignment go and make an investment in that experiment level. That's one path. So another path is that, with vendors here, that if you want to think of your R&D alignment and you want to develop something new around that same thing, then maybe there's a different structure financially. So, but yes. But grant money, absolutely. I am blessed and lucky enough that about a week before I joined Holyoke, they were awarded a Blue Cross Blue Shield health equity grant for $900,000. So I can't, I should have given vendors that number, so sorry about that. But yes, to have that ability to unlock some of this innovation, it was quite helpful, right? So now we have the seed fund to go after that value-based care alignment. So.
Joe, great presentation.
Thank you, buddy.
Wonderful. You're welcome.
Yep.
So one of the things that I thought was interesting is earlier you asked about the digital transformation, what we don't like about it. So I thought maybe in this therapeutic setting, I could share what I don't like, and kind of maybe people can agree or not agree. But I really don't like going into a portal and answering questions about COVID and being cleared and going into my dermatologist's office to say, oh, I have the COVID questionnaire for you. I'm like, yeah, I did it on your portal. Oh, well, we're not integrated with that. I'm like, okay.
Yes.
Can I come in and help you fix that? No, it's just like, really? Like, why did you make me do it then? Like, that's so right. I think that's one thing as patients that drives me absolutely nuts because I'm busy enough, and I don't know if anyone else feels that way, but I thought in this therapy session I could share.
I think that's a very common theme for sure from our consumers, from our patients. And but on that topic alone, I'll share another story. As we deployed this new system of text outreach, it also includes a kiosk check-in. So when you come into the clinic, it's the first time you answer all these questions, and we added social determinants of health, SOGI, rel data. And the whole pitch from the vendor was, it's like being at the airport. You go in and check in, you scan in, you're fine. Yeah, but at the airport, they're not asking me 30 questions about social determinants of health and gender identity. It's going to be different, right? So have the patient do it once and then share that data. And we still have the breakdown of exactly that. So just, I forget what day, anyways, probably the end of last week, working with a vendor to be able to bring that up into the framework of the workflow. Know my patient, click it. They already completed the COVID. They already completed the social determinants of health. They already did this, they already did that. Don't ask them again. Streamline the process, right? So it's, health systems just need to step back and look at that flow, but that's a dissatisfier for sure. I have one more innovation story for you that I want your feedback on, but any more questions? Yes.
I was curious about your 5% bonus idea. I really like that. I can see that's something a lot of people, okay, that's an idea that I could, if I could get on board with actually submitting my ideas.
That's right.
How did you implement that? I specifically think of coworkers who, are the lowly analysts who might not want to be the one to bring it up because they're afraid their manager or director are going to be the ones that are going to end up getting those bonuses. How did you make it so that as somebody who down near the bottom comes up with an idea and that thing can get them excited about doing it.
I can't take credit of this one. Guess where this one came from? Our CEO. Our CEO is sitting there looking at the market, looking at the financial situation of the health system, so we have to do something different. Where can we get good ideas that cut costs rather than just telling everybody, hey, we're going to slice the budget by 7%, right? So create that program. If you save 10,000, you get the 5%, whatever the percentage comes out to be. But it's that innovative leadership at the top that helps drive that program. I've seen it before in other health systems where it's 10%. So, but it just starts with, okay, what is the impact? It's almost like that 40% or $40,000 nurse recruitment bonus. The financial push down is on the traveler side. It's making a huge impact and also drives the culture of the organization. Everybody's focused on outcomes and things of that nature. So I hope that helps. Yeah. Number one issue from a patient experience and a quality number perspective for us is that patient that is given their discharge instructions, go home, a few weeks later, a few days later, they get the Press-Ganey survey, and they go, what do you mean discharge information? And they score you low. What if there was an application that could videotape that discharge process, bring clinical information to that same view, and then be able to give that to the patient and have them identify loved ones or caregivers to share that information with. So when they get home, they're off their medication, their medications, they're recovering, et cetera, et cetera. What did that doctor say? And click on that video to be able to see that discharge process and then be able to score our patient satisfaction scores much higher. Has anybody seen a solution like that at all, or developing anything in that space? Okay, I will develop it and sell it to you all. But thank you. If there's no other questions, okay. Thank you all for your time, and I hope you enjoyed it. And again, I hope I landed on this objective. We good? Okay. Well, thank you all. Appreciate it. Thank you.